This video we will talk about extremely important CD5 markers. So there are some CD5 markers that are extremely important that we should be very much on top of them. So let's see. So first of all, let's talk about in aspect of the CLL and the mantle cell lymphoma. Now CLL is pretty much indolent disease, but mantle cell lymphoma is pretty aggressive disease. So it's very important to differentiate among two of them. So in both of the disease, CD5 positive and CD10 is negative. So CD5 positive, CD10 negative is common in both mantle cell or CLL. Now, again, as I said, CLL slow growing leukemia with longer life expectancy, while MCL is way more aggressive lymphoma with a shorter survival rate if left untreated. So how we differentiate between them? Now CD19 bright, CD20 dim, CD200 bright are consistent with CLL, and CD200 bright is not consistent with mantle cell lymphoma. Just think like, let's say 200 years, someone is going to live 200 years because CLL people live very long. I mean, doesn't mean that really they live 200 years. I mean, just to kind of like to memorize, to make it in the morning. So CD200 bright in CLL is basically it's a kind of like feature of CLL. So CD19 bright, CD20 dim, CD200 bright are very consistent with CLL. CD200 bright is not consistent with mantle cell lymphoma. Now next topic, now the same. Now I'm gonna, so this is just the rough I told. Remember these three things: 19 bright, 20 dim, 200 bright, CLL. CD200 bright is not mantle cell lymphoma. Now to further dive deep in the topic, CLL will be having CD5 positive, CD23 also positive, 43 positive plus minus, CD10 is negative. As we said here in the beginning, that CD5 and CD10, CD5 positive, CD10 negative, they are present in both in mantle cell or CLL. So here again CD10 negative. Now CD19 positive, CD20 dim, SIG surface immunoglobulin dim, and cyclin D1 negative. Some cases may be SIG, maybe SLG bright, or CD23 may be dim in maybe in certain cases CD23 negative or dim, but usually CD23 positive. But cyclin D1 will be negative in CLL. That is very important. Cyclin D1 will be negative in CLL. Now, mantle cell lymphoma, some cases may be CD23 positive, just like the way CLL, but some cases. But what is the important thing is cyclin D1 immunohistochemistry or FISH for T1114 should be considered in all cases, especially for those with an atypical immunophenotype. So cyclin D1 is always negative in CLL. Cyclin D1 is always positive in MCL, with FISH for T1114 should be considered in all cases, especially those with atypical immunophenotype. Now CD23 dim or negative, CD20 bright and SLG bright, they are kind of like features of kind of like atypical immunophenotype. Okay, now let's see what is CD200 positivity may distinguish CLL from MCL, which is usually CD200 negative. CD200 negative in MCL and CD200 is positive in CLL. Now some other markers, LEF1 and SOX11 may be helpful in suspected cases of MCL that are cyclin D1 negative. Very, very rarely cyclin D1 comes negative in patient with MCL, very rarely. So let's say cyclin D1 is negative, but patient is very aggressive and the overall picture does not fit into CLL, then you will order these specific tests to differentiate CLL from the MCL. Now, once again, CD5 positive, CD10 negative. It includes small lymphocytic lymphoma, CLL, which is CD23 positive, and MCL, which is CD23 negative. Now, let's talk reverse. CD5 negative, CD10 positive. What are those cases? Follicular lymphoma and Burkitt lymphoma. MCL can occasionally be positive for CD10, while DLBCL can be while DLBCL can be CD10 positive. You know that rare things may happen, but usually CD5 negative, CD10 positive with follicular and Burkitt cell lymphoma. Now both are negative. In what conditions they are both negative, CD5 and CD10? Mature B-cell lymphoma such as hairy cell leukemia, which is always CD11C positive, CD123 positive, BRAF positive, HCL, PLL, CD11C positive, CD123 negative, but BRAF negative. Then we have the marginal zone lymphoma, lymphoplasmacytic, and Waldenstrom macroglobulinemia. And CD15 and CD13, CD15, 30, 15 positive, 30 positive are features of Hodgkin's lymphoma. Now in this slide, again, we are going to talk about some more markers. CD34 positive is a blast. It's present in acute leukemia. CD3 positive is in T cell. CD19 positive, also CD20 positive B cell. Now which drug? Rituximab acts on CD20 B cell. CD33 positive is myeloid cell. 34 blast, 3 T, T4 tri, 19 and 20 B cell. CD33 is myeloid cell. Now if patient is CD34 positive, CD19 is positive, this is B cell, because this is B cell, this is B cell ALL. If patient is CD34 positive and CD3 positive, this is T cell ALL. If patient is CD34 and CD33 positive, this is AML, because 33 is myeloid AML. Now 34 negative and CD33 positive, this is acute promyelocyte. It's promyelocyte, so they are not they are kind of like not blast. And CD34 mature cells, they don't have CD34, and also CD34 is not present in CLL. Now remember one thing, team, CD38 is a protein found in multiple myeloma cell, indicating a more aggressive disease and making it a prime target for therapies like anti-CD38 antibody daratumumab. It's a protein found on multiple myeloma cell. CD38 is also expressed on CLL cell. A high level of CD38 expression is associated with a poorer prognosis and more aggressive disease progression. So it's present on both cells, CLL cells and multiple myeloma cell. In multiple myeloma, the therapy daratumumab again is against CD38, but in CLL, CD38 having this is considered worse prognosis. So these are some important markers, CD markers, that are very, very important. So just keep these markers in the top of your memory, and they will always help you to diagnose